I have the privilege of introducing just the moderator, although I would love to introduce all of the speakers, but I'm just going to introduce the moderator for our final panel. And I'm going to do it by saying more than he'll want me to say. So in October 2015, I got an email from a guy named Curtis Chan, who is a pediatrician and at the time the director of the Maternal Child Health Department at the San Francisco Department of Public Health. Curtis was writing to send on a question that he had gotten from the medical director of Alameda County's Healthcare for the Homeless program, who was interested in strengthening the county's information and referrals resource. And about a month later, when our schedules could align, because you know it takes a long time, I had the opportunity to meet the good Dr. Damon Francis. Yeah, bring it. At a cafe in Oakland. And I can honestly say I have never enjoyed a coffee conversation quite so much. Since the moment we met, Damon has pushed me to think more critically and more radically as I look at what I do and how I do it. He does the same for every organization that he works for, whether as the medical director and a clinician in Alameda County back then and again now, as the chief medical officer at Health Leads, where he would go not long after our first conversation, or as a trusted SIREN advisor. Damon's given me 10 years of invaluable advice about our shared field and about everything else. And I'm quite sure that if he keeps answering his phone when I call, he will give me 10 years more. Every time, the advice that he gives me is clearly a product of both his brilliant mind and his very big heart. So there's no one else that I trust more to both direct and hold space for the conversation to follow. Damon, thanks for walking us through our final event at the SIREN 2025 National Research Meeting.
Thanks. That was definitely more than I wanted you to say. So the title of our talk is not 1,000 Flowers Bloom, it's 1,000 Flowers Bloom. And some of the administrators where I work and maybe where you work say when you have 4 doctors in a room, you have 5 opinions. And I'm quite confident we're going to break that record pretty easily, right? Like, put that up there and we're just going to knock it out of the park. Yeah, our hope is really to have a kind of shop talk type conversation. And I have some questions teed up, but I think I would really like us to get to that level where it feels a little bit more like shop talk, and I think it's valuable for both kind of the explicit content of what do we want to show investigators, how policymakers, leaders of large population health programs kind of think about the evidence, think about the implementation of the evidence and understand it, and then those of you who are practitioners and policymakers also just kind of get to have a little shop talk to like round out this conference and maybe start to integrate some of the ideas as you go back. So yeah, I'll encourage us to kind of prod each other and just get past the questions and start talking, which I don't think will take too much with this group. I'm going to let you all introduce yourselves, so please just take a few minutes, starting with you, Monica, your name, your organization, and then one kind of large-scale social initiative that you've been working on that you're proud of that you want to talk to us about.
Great. Well, hi, nice to be here with everyone. I'm Monica Soni, the Chief Medical Officer at Covered California, which is California's state-based marketplace. We are essentially a startup within government because we were created after the Affordable Care Act and just had a record open enrollment. So we are now, 1.9 million people either renewed or enrolled for the first time on the exchange. And I'm a primary care internal medicine doctor. One of the population health initiatives that we're deploying right now actually starts tomorrow, which is very anxiety-provoking for me. But essentially, we had a program that was assessing the quality that our health plans were delivering to our enrollees, and for underperforming health plans, there was some financial incentives. So we had some plans that underperformed and didn't hit our target last year, so there was $16 million sort of out there that we got to think about what should we do with it. And what was really exciting was we just decided to go talk to our folks. So we called and surveyed our enrollees, which are a very interesting kind of sliver of the population, right? It's folks who don't qualify for Medi-Cal because of income, don't have coverage through their employers, don't have Medicare, and so they're kind of right in this gap of not having a lot of benefits. And that's what they told us. They said, we're just struggling. Over 47% of our folks said that they don't have enough means to just like live and get by. Huge numbers of folks. And so because of that, what's launching tomorrow is actually what we're calling our grocery support program. Folks will get cash on a reloadable card for a year. Folks that have chronic conditions are low income, FPL less than 250%, and screen into food insecurity. So thousands of folks across California will be eligible for this who are covered California enrollees. We're also funding child savings accounts for all of our kids who are 2 and under. So if they go to their well child visits, get vaccines, we're very permissive in all of our programs, but do those things, then up to $1,000 will get deposited into their accounts for upward mobility and education. And then we really piggybacked off of a program that my counterpart here had created, and the rest of the funds are going to primary care practices, which support Medi-Cal enrollees and covered California enrollees. So yeah, that one we'll see how it goes. We've got some amazing academic partners and evaluators who will let us know if the impact is where we want it to be.
Cool.
Hey everyone, Palav Babaria. I work for the California Department of Healthcare Services, which administers Medi-Cal, which is what we call our Medicaid program here in California. We cover about 1 in 3 Californians, or over 14 million people right now. And me and my team are responsible for ensuring quality, equity, and pop health outcomes across those 14 million people. Many of you have probably been following California's journey, like many other Medicaid programs, with our 1115 waiver. So we definitely have enhanced care management and community supports, which are also in lieu of services, paying for things like medically tailored meals, home modifications, et cetera. That bucket of work, which we are about halfway through our 5-year waiver period right now, really is aimed at that 5% of our Medicaid population that costs about 50% to our state and federal budget. So that's one end of the spectrum. I think the Pop Health initiative that I'm actually most excited about that launched earlier this year is really around how we can integrate public health and healthcare better. So when we talk to our public health colleagues, right, they do population health with a capital P, and we on the healthcare side are often population health with a little p, and there's a lot of space in between those two approaches. And so we launched new policy last year where instead of our managed care plans, and currently in Medi-Cal, about 99% of those 14 million people are enrolled in a managed care plan. So that is essentially our delivery system. Instead of working in their own silo to understand what the community needs and tailoring their services to that population, we are now requiring them to piggyback off of public health's community health assessment and community health improvement plan approaches, which are required for public health accreditation, so that instead of having survey fatigue for all of the CBOs and members, how can our public health departments be the backbone of truly understanding what a community needs, and then our healthcare delivery system is responding to those needs, thinking about upstream investments rather than the really sort of downstream pieces that we often focus on. And as a part of Prop 1, which is also our state's overhaul of our millionaire's tax that funds a lot of behavioral health services, county behavioral health departments are also going to be joining that fun local public health party starting next year.
Sanjay.
Thanks. Hi, I'm Sanjay. Nice to meet you all. Primary care internal medicine. I'm here representing Waymark. Waymark is essentially a free street medicine service for patients receiving Medicaid and their primary care providers. We sort of learn from the cool initiatives in California and bring it over to states that don't have dedicated funding for these programs and help primary care providers fund the programs through shared savings. So right now we have a little over 100,000 patients, about 2,500 different providers, and what we do is train community health workers, care coordinators, social workers, therapists, pharmacists, and give them some tools, and their full-time employees have ownership in this collective PBC, a public benefit corp, that essentially gets self-funded through the reduced emergency room visit hospitalizations that are achieved through these programs, as well as the improved HEDIS measures that normally health plans receive the benefits of. And so what we do is give them certain types of technologies in order to assist their work. So far, we've, versus a matched control group, reduced emergency room visits and hospitalizations by about a quarter, HEDIS quality measures by about 12 percentage points within a year. Most importantly, achieved about 2/3 of patient-led goals. So the approach is to kind of learn from the initiatives here in California and places like Contra Costa, the LA Barbershop Study, et cetera, and enable patient-based care outside of the walls of the clinic. So excited to be here.
Yeah. So I think, part of me wants to just like jump up and down and go like, woo, about some of the stuff you guys are doing, because I feel like we're just talking about it in this kind of understated way. But Lauren Taylor, she talked about these wearing bifocals. I don't think you guys were here for her talk that opened it, and really wanting to work on these sort of short-term, what Dr. Berkowitz has called mitigation strategies, and this longer-term vision for a healthy society. And I think what really excites me about all of the things you guys are talking about, first of all, they're happening at very large scale, but they're engaging kind of multiple different theories of change. They're not just the theory of change that, if we provide a social resource, then someone's social health gets healthy, social health gets better, and then their health, their physical health and mental health gets better. They're also really about societal strategies. They're pushing toward this longer-term lens of money directly from the healthcare system back in the pockets of the patients that we're serving the worst. Like, if healthcare isn't doing it right, give the money back to the patients, right? Have healthcare be accountable to its public health obligations, right? Create an employment strategy for an enormous workforce that's necessary, that we know is necessary, with minimal burdens. And I think, for me, I think those are all kind of responsive to that multi-level approach that Lauren was talking about, and what I think makes a lot of the work that you guys are doing really special. But I'm curious, among you, where do you see boundaries in sort of applying some of the lessons from other places? Like, Sanjay, are you thinking about direct assistance in what you're doing, of the sort that Monica told us about? Palav, where do you see like limitations in applying some of their strategies and what you're doing, at the health department? So maybe start with you, Sanjay, and then come back this way.
Sure. I'll be fast and let the experts here weigh in. I'd say from our side, what's been really interesting is embedding randomized trials within the work, and then trying to, within the community-based organizations, align on trying to get better evaluations so that it's not just like a pre-post comparison or regression to the mean that's being attributed as being an intervention effect. That's always hard because there's organizational tendencies to want to show a good effect, but we know most things don't work, and that's okay, and it's probably better that we know the important informative nulls. But a few things have been really interesting in terms of integrating the social determinants data better into our healthcare data. So for example, learning from some of the work at UCSF, we see the hypoglycemia among patients with diabetes on insulin who are food insecure spike in the last week of every month among those states where SNAP benefits are at the beginning of the month. Very intervenable. We proactively now call those patients, work with the food voucher programs for that last week coverage, have the pharmacists adjusting insulin for the last week of the month. These wildfire smoke data now being available, we've integrated that so that our asthma and COPD registry, we can get early refills done, and we see a neutralization of the nebulizer bump in the ED during the wildfire smoke passage. So the availability of this data has been so helpful for proactive intervention, and I think that's a big positive.
How about you, Palav? Any positives or negatives from what you're seeing elsewhere that you could or couldn't integrate into what we're doing at this state?
I think it's a great question. I think some of our challenges, right? California really cares about its underserved population. So as a state, we have so much political will to do the right thing, to invest billions of dollars in our Medi-Cal transformation right now. But that's a double-edged sword. And so I think a few things. One is that we have a lot of programs across the state of California. And one of our biggest challenges is how do you break down silos between those programs, because there's so many redundant, duplicative efforts happening. And that was a big part of why we revised our policy around these community health assessments, because having 10 different entities all assess the same community, come up with their separate strategies, not align how they're doing investments, not align how they're doing local transformation is just not helpful to anyone. And that's a very different situation than some of the other states, for example, where Waymark is operating. And so really thinking about how do you not duplicate efforts, especially in areas where, yes, we all have resource constraints, but relatively we are more resource rich than other places. Obviously, in a Medicaid environment, federal policy affects us too, and so there are boundaries to what we can do in terms of what we can get approved in our 1115 waivers and with the federal government. California excitingly charted the course with our justice-involved entry program, a lot of the social services that we're providing, but that is always going to be an inherent tension of how can we push the envelope as much as possible when some of our authority is limited by what is happening nationally. So maybe I'll stop there and then see what Monica has to say.
Yeah, I'll just add with this idea of breaking down silos. I mean, I have the privilege to work with one of my best friends for my entire life, but because of that, we have very strong relationships across the state now. Medi-Cal, of course, being the big fish, but between Covered California and CalPERS, the 3 public purchasers in California represent over 45% of all Californians. So that is market power, right? And so when we decide that something's going to happen, either in a contract or alignment on measures, or frankly, even thinking about how money will flow from plans to other places, it impacts what all of the health plans do, even ones that we don't have contracts with, and therefore the delivery system. And we hope mostly in positive ways, but that's where the feedback loops are so important. And so I do think we are breaking down silos in that space, but we have different constraints, right? The exchange is very interesting. We mostly don't have the lever of making things a benefit. Right? We have metal tiers, and the metal tiers have an actuarial value, and you cannot exceed that. And so part of the reason why our program is structured the way it is we really didn't have a way to do something like medically tailored meals, and so we decided to go back to you all and say, okay, well, what are other ways we can address the food insecurity that we're seeing that would be smart and thoughtful and that we could still study, but is outside of a benefits perspective? Frankly, it gave us a lot of freedom that you don't have, but maybe means that our ability to scale is a little bit different.
That's really fascinating. I like this idea of thinking about, all the market power when people start to coalesce at the state level. I think we've been talking about localism, about states being really important. I imagine in your seats, you're entertaining a lot of proposals for a lot of different flowers. And some of them you're like, oh my God, that smells like skunk plant or, carrion plant. Like, that is not a flower that I want to. And so what are the things that you see out there? I mean, I certainly have them, so if you guys don't have them, I'll stand up there and start talking about them. But what are the things you guys are seeing out there that we're doing in implementation where it's like, just let's rip that flower up and not plant it again, that that people are proposing to you?
Well, I want to know what you think is stanky, because that would be I like to learn from others.
We can all show our best stank face. I feel like whoever earns the best stank face up here, that means don't do that, guys, okay?
Mine's is only moderately stanky. I mean, I think for me, because California is gigantic, and what's happening in the far north and the needs down by the border are very different, right? And even across LA, what the needs are very different. And so I think what I really struggled with when I was trying to translate what the researchers were showing to something I could do at across the state was the studies were really pilots or demonstration projects and really hadn't thought about scale. And so there was a lot of work to say, okay, how do we build something that's not just one flavor, right? How is it not just one? If it's a popsicle shop, it's just not the one popsicle that I have here, and then over there is ice cream. Like, how do I have 10 flavors that work for all of the diversity and plurality of the folks that we serve? And so that's really my challenge. It's not a particular intervention. It's more like, did we think a little bit more expansively from jump? Was it designed with the idea that, yeah, some folks might want a high-touch human intervention and some folks an EHR push is enough? Like, I don't know that that's how things are designed, and I appreciate that sometimes the research community needs it to look a certain kind of way, but then I can't take it and put it into action.
Yeah, I often don't like the word implementation science, actually. I think there's science implementation. and a lot of the realities of what you have to do around implementation are based on these societal structures that are almost, even in friendly administrations who espouse the same values that we have as a research community, are still not really touchable conceptually. What do your union contracts look like? What does this space look like? Does that resonate with you, Palav?
Yeah, I think just one thought to piggyback off of Monica's, before I came to the state 4 years ago, I spent my entire career in the healthcare delivery side working in FQHCs and public hospitals, and I ran operations, right? And so that is how my brain thinks. And we have amazing policy in California, and yet when you look at what is actually happening on the front lines, when I'm in clinic every Friday morning seeing patients, I am still ramming my head against that brick wall of everything that is not working in our program. And then I call up my colleagues, be like, did you know this is broken? You have to fix this tomorrow, right? But I think it's sort of, the research is great and, helpful, but it is not usually the what that trips everyone up. It is the how. How do you manage the union contracts? How do you scale across a state that has huge geography, rural, urban, different workforce challenges, different pipelines? And I think the more that we can really start to think 10 steps ahead through that implementation pathway, then we will be setting up all of the implementers and policymakers for success. But I rarely see that sort of in my seat today. I get these pristine models, and then it's sort of, well, how do you do that for 14 million people? No one has any idea. And then the second stinky flower, I would say, is really, and I say this as a doctor, right? Like, doctors in healthcare think that they know everything about everything and they do it best. And what we have seen is, especially as healthcare is moving into the social services space, the healthcare model is not the right solution for the vast majority of what our members need. And so it's great. We want to figure out how to leverage these healthcare dollars, because that is the only sort of sustainable funding source we have right now to do this work. But how do you do that without over-medicalizing? How do you do that without actually, bringing in preconceived notions and downstream interventions, as opposed to letting our social services partners and public health do the upstream work that is better, more effective, and that they do best? And that tension is something that we are seeing every day as we're rolling out CalAIM.
I'd say one of the stinky flowers that I feel like I may have self-planted is
Love these the best.
the contrast between all of the push we have for primary care providers to go along the HCP land value-based care pathway, and yet all of the fee-for-service trickles that come every passing year in different forms with different requirements in order to try to support primary care with the other hand. The collaborative care model payment, the separate fee-for-service billing codes for CHWs, this, that, and the other. They're all with good intention, and yet it's hard for the primary care providers, who love to complain, and they have good reasons for doing so, about having so many different contracts with different quality measures. And then one asks, why aren't you billing for this? I didn't even know it existed. We don't have a billing department. Why is this private urologist having so many collaborative care for service? Because they have a really smart billing department who's like, playing the game. And the people we care about most are not able to or have the infrastructure to do so. And so I think we need to reconcile the desire to add another fee-for-service code to support something that is probably good with the reality of being pushed into increasing value-based care that was supposed to be transformative care under a capitated basis with some socially adjusted performance bonuses, and there's a lot of tension there.
Yeah, I mean, speaking of sort of, I helped plant that. Like at Health Leads, we had
Your fault.
these like 30, these like 30 outcomes for like specific diagnoses of different types of food insecurity, right? And what got people so excited about the idea of we can do something about this was like you could show these sort of specialty outcomes on a very short basis, all of which are extremely likely to recur. And yet that sort of mental model undergirding, like this is a specialty diagnosis that you can make. A social need is a specialty diagnosis that a doctor is going to make and then write a prescription. And that's going to get us to some resolution, some durable resolution. I think the widespread implementation of hospital-based screening for these diagnoses that aren't really treated in that way in the community, at least durably, is a real downside of some of the work that I've done in this community, and that's led to kind of this monstrosity of eligibility forms and different ways of characterizing people when what they need is a relationship with someone who cares over time that has a set of relationships themselves and a set of resources in the community that they can activate on their behalf. I think those two models are really, really hard to integrate, and one lends itself to research, and I think the other lends itself to practice, and I just think something's falling down in that translation. Yeah, I don't know, any more comments on that, kind of missing elements of translation? Because we as a community focus on dissemination, but I just have found, I'm really sad, at how a lot of what I've talked about and promoted has been translated into policy.
I'm going to nominate you to respond to this only because I think it's something that you said that a little bit responds to that, which is your optimism a little bit right now, and that maybe some of the challenges that folks are facing could lead to a better future where we're not doing this ticky-tack work. So I don't know if you're willing to sort of share a little bit about that.
Thanks, Monica. I think some of it, when you're doing screen and refer in a clinical setting for social needs, that is downstream and reactive, right? And I think that's part of the problem. So yes, it's not that it is bad. In that one moment in time, when I write a prescription to go to our food pharmacy, at the clinic, yeah, that individual and their family, maybe that one day, I feel good, they feel good, but that's not what the root cause of why people have food insecurity, right? I think about the state of California. The fact that 1/3 of our residents are on Medi-Cal and meet eligibility requirements for Medi-Cal, that is the problem. And how are we taking the long view and thinking about how to get families out of intergenerational poverty? And I think that's why some of the work that you're doing around putting the money back into pockets is so exciting. Or same thing around, whether it's housing insecurity or food insecurity, they are manifesting and we are putting our healthcare Band-Aids on them, but we are losing sight, I think, at some point of what the long-term the long game is here. How do we really lift up our communities that we are trying to serve out of poverty? And we're taking one step. So within the Medi-Cal program, when I joined our team and we did our pop health framework, we said we were going to stop doing raise your hand if you know what the staying healthy assessment is. It was this god awful form that I had to roll out in my last job that has 50 questions. It's a paper PDF that then you have to scan and send to the state into some filing cabinet that no one ever sees, and it asks questions about food insecurity, yes or no. And I can tell you the questions were asked because that was the state compliance effort. And then nothing happened, right? Sometimes people got a handout for the food pantry. Sometimes they said, go to the social services and sign up for, CalFresh or SNAP. But for the most part, nothing happened. We had no outcomes. So I was like, great, we can stop that busy work. And now we're trying to take a data-informed approach. So over the last year, we now have data sharing agreements with our SNAP program, which is run out of social services, and our WIC program run out of public health. So we are getting data on every single person in the state of California who's on Medicaid, who's eligible for those programs and not enrolled. And now we've woven that into our managed care contracts to say, hey, your job is not write a prescription, send them to a food pantry once. Your job is get these people in a seamless way linked up to benefits that are already funded that can help them in a more durable way. So I think that's one way to push things upstream. Is that the same as, hey, let's get you a job that pays a living wage so you don't actually need to be on SNAP and WIC? No, but I think thinking in all of our work, what is that one step upstream that is sort of the permanent solution, right? If we all do our jobs well, we should be working ourselves out of our jobs.
That's a good one.
That's my soapbox rant for the morning.
You were writing something down. Go ahead.
Oh, no, I was just data sharing agreement with Wiccan. That's a takeaway.
I was sort of thinking when Lauren was presenting, I just thought that bifocal kind of metaphor was really beautiful, but I was thinking it's the progressive lens, right? We actually need a bridge from what we're doing to where we're going, and I think your comment really spoke really eloquently to that. One of the places I think that it's also kind of stinky is how much we talk about, in particular, racial equity in the context of the work we do on social interventions, and then how much we publish results that demonstrate that we've improved racial equity. There's an enormous gap between those things, and there's a lot of reason to believe that particular navigation work that involves filling out a lot of forms actually would make that gap worse, right? That gatekeeping would make that gap worse, and yet it's not really interrogated so deeply. How do you all think in your roles about racial equity, social interventions, how they play well together or don't play well together, kind of at the state level and in the states you're working in, and particularly at this moment?
Sanjay?
Do you see what she's doing here? She's really good at assigning out work.
Master facilitator.
I told Sanjay we're going to get steamrolled, and he's like, I live this.
Based on
They're
the
married,
Socratic
they're best
method
friends.
quite a lot. We're going to get you back. We work in a lot of quote unquote red states. And most of the people who we employ are currently feeling attacked. That's what they would say during town halls. And we're not allowed to say equity if we're funded by any social impact bonds at the current time. We've gotten those memos earlier this week. I think we also can't say pregnant person. That was Monday. I think Tuesday we were allowed to say pregnant instead of, we changed it to parasite for amusement purposes. Human parasite wasn't going well either. So, it's an evolving landscape and every day is different, but I think what I'm thinking about this week is, in the California world, it sounds awful to be like, you're not measuring enough, but I'm wondering about not being allowed to measure. And so I think one of the challenges we are trying to be more proactive about is just refusing to comply. And that's, part of the, the very California heavy crowd. That was not the reaction on a Zoom call in Kentucky earlier. And that's our choice and our response, but I think that's a lot of what we're working through. Because, on the other hand, we also are responsible for employing people. And so we can't, as a PBC, we're lucky that we don't get funded through grants. We're self-funding through the shared savings, and that was intentional.
Let's say PBC.
Oh, sorry, Public Benefit Corp. It's like how some libraries and transit agencies starting in the late 90s decided to not be as susceptible to funding fluctuations. And so you can get bond income. A lot of community colleges have decided to go this route. It's different from a 501c3. It's not a nonprofit, so we're not allowed to keep an endowment. We have to reinvest the funds. I like to remind people the NRA is a 501c3. So 501c3s can operate in ways that may not be consistent with public interest. Whereas in the states we operate in, the state gets to inspect us every year and say, are you operating in the public interest? But yeah, we're subject to state inspection. So if I piss them off too much, your counterparts in Kentucky and Arkansas may say, we're not going to allow you to continue to employ people in the state. And so I think that's, we can be on a high horse, we can be on a medium horse, and we can be on a low horse. I don't think we're willing to be on the low horse right now, but I think our high horseness about, refusing to comply is balanced against the worry that will cause unemployment among our staff.
Yeah, I just think it's so important to think also about the accountability frame in which you make those decisions about where to sit, right? So when you're accountable to the public to make that decision, that applies certain pressures. When you're a nonprofit, I think Lauren was talking a lot about, who you have to report back to as you're making these normative decisions in managerial and leadership roles. And so I think that's a really key element of some of what you guys have done, and really appreciate you walking us through kind of how that affects how you're thinking about this moment. Monica?
Yeah, for me, we spend a lot of time at Covered California trying to be surgically precise about what are we talking about here, and not blending things that are social drivers and things that we think are embedded in historical racism. And that's how we treat our data too. And we're just lucky, right? We have very robust data. Our self-reported race, ethnicity, and other categories, 80% complete, and we have full claims. And so we slice and dice by everything, right? Got a team over there. We do rural, urban, super rural. We do income. We do all the things, and we a little bit, because we have the privilege to do that, let the data speak for itself, right? And sometimes what we see, and fine, this is a downstream view of what we're looking at because it's claims-based, but some of what we see is, income is driving that. Some of what we see is actually just the high deductible bronze plans are driving that. And I gotta say, from an equity perspective, we see more of that than almost anything else. Plan design and the immense financial sensitivity of our particular population is what's driving that. And then sometimes it's just good old-fashioned racism, right? So it depends on what we're looking at, and I think we try to present it all, look for it all, and then solution for the actual problem in front of us, and we do not allow our plans to conflate the two things. Your transportation program isn't gonna solve the racism. So, that's what we challenge them on.
Where does the research literature as it's published sort of fit into that analytic work that you're doing, that sense-making work that you're doing?
Yeah, I'll just say from a norm perspective, we're hyper-transparent. So we publish everything in the world for all to see. And when we read what you all write, we try to look for that too, right? Do you reflect the population that we serve? Are you being precise with what you're driving for here, and what the outcomes show? And yeah, a lot of times we'll take what someone will publish and try to run it up against our own data to see does this look the same for our folks or not? And if it doesn't, we a little bit abandon that, particular set of analytics.
Mm-hmm. What about what research can't show you? What about the sort of interpretive elements, that come from bringing your life experience to something? How is that integrated in what you're doing? And then, other panelists also.
Totally. I think it was an interesting gap when I came to Covered California, because I'm a primary care doctor, so I'm just used to talking to people myself. And that had not, we do a ton of focus groups, ton of qualitative work in the enrollment space, right? More traditional, or how do we make sure we get people covered, that kind of work, really sophisticated work in all languages and all parts of the country, state. But we really didn't do that in terms of our outcomes work or our quality work or our equity work. And so we just started to cold call people. So we just would pull our list and we'd be like, hey, it's Monica from Covered California. Can I ask you some questions? We did that for hundreds of folks just to get a sense of what are people telling us. And then we started to do surveys again, like qual surveys, just talk to us, tell us. We started to talk to providers who serve Covered California enrollees just to hear what's your experience on the ground, what's happening. And that has been just as impactful as anything that is quantitative. And so we are working hard to allow for the space for both of those things. I will say the challenge for us though, and I want to just be honest about it, is it hasn't left as much space for community-based organizations because we're going straight to our enrollees. And a lot of times, again, our enrollees are a particular slice of the overall population, so folks want to use Medi-Cal experience to inform what we should do, and it's not the same. Our folks have different challenges and distinct challenges, so I don't feel as comfortable using some of that to make our decisions. I want to hear directly from our people.
Yeah, I wonder if that's also part of one of the things we should talk more about as a community, right? In this election, we saw Black and brown communities move more toward voting for the Republican candidate. And a lot of, what's hypothesized about that is that some of us as leaders who are coming from certain class backgrounds don't represent others of us, right? And I think you're highlighting an element of that. And is the research we do, the ways that we package it, sort of contributing to this distance between the represented and the representers, and how do we make sure that we're really doing that? I mean, I think going directly to the beneficiaries just strikes me as something that's obvious, but something that is not always really in the conversation. It's not always something that we do. We do a lot of stakeholder consultation that kind of misses that obvious step.
Yeah, I think, on the data front, similar approach to what Monica described for Covered California. And similarly, so for our Department of Healthcare Services, we just launched our 5-year strategic plan. And one of our explicit goals is how do we get the workforce at our department that is making state Medicaid policy to be reflective both of the diversity of California, but also our Medi-Cal population that we serve. And today, we are just far off from that goal, but I think that is exactly the intention, right? You can make assumptions, and that is very different than actually having people with lived experiences, with a seat at the table, making decisions. We've made a lot of inroads in the last few years, so now we have a member advisory council that is made up of Medi-Cal members who meets with our director and our exec team every quarter to advise on policy. We actually today just launched our Birthing Care Pathway report. You can Google Birthing Care Pathway and DHCS. That's my plug for all of you to go read it. But that work, we had sort of a broad group of Medi-Cal members who are pregnant or postpartum or had abortions or miscarriages and other types of pregnancy losses, really inform that work from start to finish to say, what is your lived experience? What of our policy and benefits is working? What's not working? What do you want to see? And just hearing their voices, we came to a totally different position than if they had not been involved in that process. And some of it is, literally people just don't feel respected and heard. Our healthcare system causes trauma. It does not invite people to engage and get the care that they need for themselves and their families. And that's not a member problem. That is a us problem that we have to fix and respond to. So I think really how you change your organizational structure, how you're having people with lived experience inform the work is critical. And then the other thing, Monica and I sat on our Department of Managed Healthcare Quality Advisory Committee. Maybe it was Alice, it may have been before you came. Whoops. Where, when you look at who's in Medi-Cal, it is the Black and brown populations across California. And so we can talk about racial and ethnic disparities, we can talk about rural, urban, but all of those disparities are dwarfed by the disparity that you see between the Medicaid population and our commercial populations. And when you look at, we did a network analysis recently between us, Covered California, and CalPERS, which covers, all of us state employees and retirees. And there is minimal network overlap between Medicaid and where you get care in Medicaid and where people who have commercial insurance get care, right? And so we have a segregated healthcare system that is also racially segregated, and how we start to unpack that, I think, is critical. And so as you all are doing analyses, like how are you looking across lines of business? Because so much of the story in our nation is hidden there.
Oh my gosh, I have so much I want to say in 7 minutes left. I
Join
want
the panel, Damon. You can just
I want to end on a hopeful
for it.
note. Yeah, I'm gonna leave it. I'm gonna leave it because I'm looking at the clock there. Thank you guys so much. I want to think about, at this really hard time, what success looks like. So, it's 2050, and health outcomes in the United States are approaching those of peer nations, and maybe, all nations are peer nations at that point. We've closed racial disparities. How did we do that? What was the pathway? I want you to speak in the past tense, if you can, like really try to sit in this future space that's like really hopeful, and take a minute if you need to. How did we get there? And what was the role of healthcare and social interventions in healthcare in getting to that place?
I did my homework last night, so I was prepared for this question.
Go for it.
So I did sit with it for a while. This is what I said. This is a hard question because I wanted to think about this a little bit more. And so in my mind, when we got here because we moved out of an extractive economic system into a regenerative one. So we no longer are actually taking funds, people, health, whatever you want to call it, out of local communities to the distance, but we were putting it right back in. And there's a number of ways you can do that, right? That's, of course, that people have a living wage, that there's economic mobility, that there's education, but it is also, frankly, that you've got primary care as a public good in the community. It's that we as primary care providers live in the community and that our kids go to school in that community too. And so it's no longer the other or the work for someone else, it is work for ourselves. And I was just thinking about my father-in-law who is in his 80s, and I tell him about him a lot because he's just a beacon of light for me. He grew up in Natchez, Mississippi, which is famous for having the highest density of millionaires from the slave trade, and he grew up in the segregated South. And he talks about his childhood as being wonderful because it was the community taking care of themselves, right? Actually, that segregated Black community educated him, got him out of poverty, and he became a neurointerventional radiologist, right? And now gets to see his grandkids living a very different life than what he lived. And it was because the community served itself. And so to me, that is kind of what would get us there in 2050.
What's healthcare's role in that? What is that? So what happened 25 years ago after that conversation we had on stage in healthcare?
So did anyone watch the Grammys? So in the Grammys, and I'm sorry, I'm a little.
No, that's great.
In the Grammys, they were fundraising for the fires, right? And so they were talking a lot about how the flowers were from the community and all this stuff. And I was like, does the Grammys not do that normally, right? Are they sourcing from LA normally? Well, what about our hospital systems and our delivery systems? I know some of our systems are starting to do this where you cater from the community and stuff like that, but is everything actually thinking about not just being an anchor institution, but actually you're part of everything? So that to me is a piece of it, right? You're not just thinking about how do you keep your wing open to do transplantation, you're actually thinking about okay, is every dollar coming in somehow getting back into the people around us?
Great.
I was just talking to someone this morning. There's a great New York Times article on the front page today that looks at how our GDP has been exponentially climbing for the last 30 years, whereas all the other indicators have really been downsloping. And I think that's exactly the extractive process that you were talking about, where economic growth is not necessarily tied to the well-being and reinvestment in those communities. I think you hit it spot on. The other thing that I spend a lot of time thinking about is that, fragmentation and segregation are sort of the enemy of everything we are trying to accomplish. And so how do we integrate locally, both to break down those silos, have data exchange, have people collaborating across sectors is really critical to achieving that future state. But then also the segregation, right? Where we talked about we are never gonna get to that amazing future state if Medicaid is a silo and commercial insurance is a silo, right? And we've seen it in other sectors, like the fastest way to get to improved school and educational outcomes is by integrating schools. And we've known that for the last 50 years. And yet we don't have a similar conversation in healthcare about integrating healthcare. And where I go and get my own healthcare looks fundamentally different than where Medi-Cal members get to go and receive their healthcare. And so we all have a role to play in that, right? How do we actually do local integration where we say it is unacceptable if you're a healthcare provider in this community that who you're serving does not represent the composition and makeup of that community, and we have a long way to go there.
How does that work? How does, yes, absolutely. Desegregation, I'm for it, for sure. How do we do it? What do you think happened 20 years ago, if we're in 2050, that we did to desegregate? Is there anything that you're seeing, in your work that's like, we did that, we got it?
I mean, I would say leadership matters, right? And I see that on a micro and macro scale across the state, that there are leaders who run clinics who say, hey, we are here to serve the community. We are gonna take our profit, we're gonna reinvest it, we're gonna employ from the community, we are gonna train, same way that Waymark is employing sort of CHWs from the communities they serve. And so I think there's a million ways that every single person in this room can contribute to that effort locally. And then obviously, yeah, if I had a magic wand, there's tons of state and federal policy that could fix a lot of this. But I don't know that we need to wait for that.
Awesome.
I like everything that's been said, and I had such a hard time with this question, but honestly, and I realize I'm on a white chair with a tie on, but I think we have to do a lot of street protests right now, and I know that's a very
From Sanjay?
I know.
So we did a lot of street protests, if we're in 2050.
Honestly, well, looking back at right now,
Yeah.
but I think I just don't see a path there where we can maintain the safety net right now without that. And I think we should approach what the vision has been that we see here, but it's just, it's been 2 weeks and it feels like 2 years, and I think we just have to have like more of a, I don't presume anyone's political beliefs, but it's the SIREN conference, so I kind of do. I just think we have to have a much stronger opposition to the massive safety net cutting to start.
Yeah. I think it is about thinking about what the political dimension of this is in a broader sense than party politics. And I think looking back, we see that we protested with different people at our sides, right? We started to make meaning in ways that I kind of crossed this technical democratic divide that allowed us to make sense of data with the members who are experiencing this, looking at the data with us, directing us as specialists rather than sort of this distance kind of technical view. I think that we learned in this election that this kind of distance between those of us in this professional managerial class and the folks that we are so keen to help need to be in better relationship with one another. And once we learned that, we took to the streets and we got our health back. Okay, let's turn to questions.
You silenced them.
And I was like, were we that boring? There's literally like not a single question anywhere in the audience.
We were too stanky.
Yeah, poll the audience, what's the stinky flower?
See if we can get some stank face going on up here, right?
Thank you, everyone. I'm Brian Frank. I'm a family medicine doctor from Portland, Oregon. And I thought I heard this reference, but I'm interested to hear more in the notion of primary care as a public good or as separate from the healthcare system, and a way that you see California or other states turning primary care into something that is not paid for in the same mechanism as the rest of the healthcare system, but instead is just a public good that's paid for universally.
So the National Academy has a publication really that kind of proceeds from this principle on primary care as a public good and what the sort of implementation pathways are. Sanjay, you maybe were consulted on that, but kind of asserts that different from specialty care, if you look at investments in primary care and the benefits they produce, it produces benefits in the way that a public good produces benefits. So I would refer you to that literature from the National Academies. And then do you guys want to speak to California and sort of how you're thinking about that?
Yeah, so in California, we actually have common language between all of our Medi-Cal managed care contracts, Covered California's contracts, and CalPERS contracts to require all of our managed care plans to start reporting on percentage of primary care spend as a percentage of total. And our recently stood up Office of Healthcare Affordability also set statewide targets in regulations now. So I think we as a state have recognized that, yes, we believe in primary care's value, we believe in that value as sort of public good, and one of the financing mechanisms to get there is to say primary care, needs to be an X percentage. It's at 15% right now with the glide path over time. And right now, most of our plans are not at that 15%, and that is based off of research and evidence that has been collected. That is one mechanism, because I think we can all acknowledge that a lot of the stuff we talked about up here, we didn't touch too much about the money, but right, it is a direct result of how we've set up healthcare financing in this country, and that is sort of the tide that we are swimming against. There are other states, so in Massachusetts, they've been trying to pass legislation to create a special fund to truly carve out primary care and have it operate more as a standalone and not sort of necessarily reimbursed through the same pathways. I don't think it's made its way through the legislature last I checked.
Yeah, I think I just want to speak also philosophically to this, because I think Barbara Starfield, who did a ton of work in sort of primary care, characterizing primary care internationally, has just an article that I go back to again and again about the connection between primary care and health equity, and that one thing that primary care can do that specialties can't do, one thing a community health worker can do that a food insecurity navigator can't do is allow the patient or the recipient of the service to characterize the problem themselves and then to work on the problem as characterized by them. Once you develop a specialty frame of mind, you're excluding context purposefully, and so you're empowering yourself immediately, epistemically, in that moment, in a way that counteracts health equity. And I think it's just such a powerful lens through which to view a lot of this work. So I just wanted to also make that point about how primary care is different and how I think it has a lot of analogies in the social intervention space. We used to talk about wraparound services before a lot of this got going, before health leads came along and said, there's the diagnoses that you can do these things for. And I think that's maybe more the right mental model for us because of that real importance of framing the problem for yourself.
Hi, everybody. Rohan Rastogi. It's great to see you guys in person here.
Hey.
I wanted to first just thank you, Sanjay, for what you said about standing up and deciding to not comply. Because I think as a early career physician, some of the comments made yesterday about not using words like equity in our organizations and in our work, it's challenging to hear that and think about how we can continue to do this work in a sustainable way while supporting the communities and signaling to them that we're on their side and continue to hold their best interests in heart. I was hoping actually, Palav, Monica, and Sanjay as well, if you guys can expand a little bit more on that and talk about how you are thinking about the idea of non-compliance, the idea of resistance, and signaling and messaging to the communities that we serve that we're still present and we're still going to continue in this work, while thinking about sustainability of your work, given that everything we do in this low-income care space it relies on federal support.
Get me to start. That's it. Like every day, there are these things that feel very personal, right? So it's not just about the communities we serve, it's literally these thoughts about me. And then we were even talking about it in my team where, our division is called Equity and Quality Transformation. I literally hadn't thought really about that because again, like we're just doing the work right now. And I think maybe that's not a healthy way to be, but I'm focused on like today, I'm gonna make sure that like thousands of people get food starting tomorrow. And like that's the work for me today. So I don't know, it's not particularly helpful, but in this super reactive environment, again, like I'm not gonna retreat. I already have what's supposed to be happening for the folks that I'm working for the next 6 months, and I'm just putting one foot in front of the other.
Yeah, I think my biggest words of advice are to like caution against self-censorship, right? Like there is a lot of chaos, there's a lot of directive coming. We all don't need to fall prey to that. And so I had members of my own team after the events of last week who were like, oh yeah, should we update all of our websites and policies to scrub out equity? I was like, no. Like we have literally, that edict has not come down. We obviously are in a state where our administration is watching what is happening federally, but also when necessary, mounting legal challenges to it. And there is literally, like on paper, nothing different about our Medi-Cal program today than what we had on paper 3 months ago, right? Like all of those federal orders, they cause confusion, they cause chaos, but nothing has actually changed in our policy, in our core values, and in our intent. And the worst that we can do is overreact and start self-censoring ourselves. And so just really staying true to those core values, which, very privileged to work for a state that is committed to equity and is committed to quality and population health. And that's the journey we're on. The work does not stop just because there's confusion and chaos happening.
The only thing I'd add is there was a handbook forwarded to me a while back that I guess the Central Intelligence Agency had made in the 60s or 70s that was about how to basically stop movements from working, and it reminded me of my academic department. It was like, in order to prevent anything from getting done, here's like 5 things you can do. Debate a lot about your titles. Have a lot of committees and subcommittees for every decision. Write long, complicated memos for what should be a simple decision. And make sure to just like insert random chaos everywhere you go so that no one can get anything. They were doing it so that they could stop social movements at the time. It heartens me, though, that apparently that manual has been downloaded a lot by .gov addresses over the past 2 weeks. But I would say that there's many ways to prevent people from getting to you when the goal is to produce as much chaos as possible in order to kind of get away with it. And I think it's important to be a bit meditative and just say, you say what you say, we're doing the work. And good luck to you, but I don't think so.
Yeah, I think I'm struck also by how I think you all have chosen really well sort of how to integrate that short-term work with the longer-term agenda. And so if you're like walking that path, like your job is just not to get pushed off your spot. It's not to react to someone else. It's just I'm walking this path, and I'm not going to get pushed off my spot. And I think that's a really different way to approach what's happening than if you're reacting to what's happening out there and you don't have your long-term path mapped out.
And I'll just say, recognize many of you in this room probably have federal funding and are potentially worried about your teams and your own employment. There's a lot of ways to make an impact, right? Sanjay is a recovering former academic who has taken a different path. Laura sends me candidates all the time. There's amazing work happening everywhere, even outside of academia, where you can still use the skills and tools you have today and really stay true to your core values. And for anyone in the room who's in California, reach out to me or Monica. We are always recruiting and happy to talk to you.
She stays recruiting.
It really does.
But there's so many ways to make a positive impact, and I think just also not losing sight of that.
Caroline, we're doing okay with a few more questions? Great, okay, please.
Awesome, fantastic discussion. If I were to ask myself, why do we have inequities in our healthcare system? I would say it's regarding our political economy of health, which is steeped in racial capitalism. Yesterday, in Lauren Taylor's talk, where she set up this kind of dialogue between 2 individuals, the question of why do we spend $4.9 trillion on healthcare and can't provide big P population health is in part because we lose so much money in our healthcare system. 100 million people hold something like $220 billion in medical debt. And yet over and over again, we talk about efficiency and value and return on investment. All this economic speak that arises out of racial capitalism, none of this is based on dignity, justice, and rights. And so I guess the question I have for you is that come June of this year, the Secretary of Health and Human Services in California, per SB 770, is supposed to create a provisional framework for healthcare for all in California, a final report by which is supposed to be submitted in November. And so I guess in this political moment, I have two questions. One is, in what ways can we move towards healthcare as a human right, at least in California, and how might that open us up to being able to take care of big P population health and actually meeting people's needs in the communities rather than fueling a financially extractive healthcare industry?
Great question, yeah, and just conveys a lot of the heat I feel, yeah. I want to just start by talking about other people who did this and policy mechanisms that are enormously important that are there for us already. So I work in a federally qualified community health center, which came out of John Hatch, who grew up in Kentucky, going to Mississippi and designing a governance model whereby people in Mississippi could decide what health meant to them and how they were going to achieve it. And that program has been spread to all states and all territories across the United States, mandates consumer governance over defining what health needs are, and then developing programs to manage those needs in a place-based context. It's been professionalized, it's become subject to the racial capitalist context that you're talking about, but its origins and a lot of what's latent in that structure are there for us, and we absolutely must figure out how to use that again. For what it was intended for why it was built. We need to relearn that history, and we need to walk that path again. So that's one thing I think on a national level that's relevant to all of us. Really understand that. I think in California, I want to see, how you all would respond to that.
Yeah, maybe I'll start with a challenge back for folks, particularly that work in more academic medical centers or delivery systems, to harken back to what you said, right? If your institution does not take Medicaid and you are working there, go and fight against that, right? We cannot go to access for all if you still continue to have parts of the delivery system that refuse to take care for us and 1 in 3 people across the state, and you are delivering the care. There is no power without you. So I would say, can you start from within, clean up your own home a little bit, before you start to go out? That would be what I would like to challenge folks to do, and I think it's the right ask. What can each of us do in the spaces where we occupy and have power to start to move towards that future state?
Anything to add?
Plus one to Monica.
Yeah, I think a lot of answers to that question for me personally, I think that's driven a lot of my thinking about my career path, like the question that you asked, and I think a lot of them are unsatisfying. And I think back to, I have a really similar story to yours. So my cousin wrote this book about Howardsville, which was a town that was founded when my great-great-great-grandfather was able to buy a plot of land that he used to work as a slave. And so my cousin went around and interviewed all the elders in our family, and they were like, and he had all these push-polling questions, wasn't it so hard? Mm-hmm. It was the worst, And because our lens on that time is that way, but I think they were quite satisfied to survive. And they were quite satisfied with their skill at doing it. Mm-hmm. And so all the questions were we had our gardens, and we hung out, and we did our thing, and we moved forward, and we had the family go. So I think that spirit of joy in just surviving, even if we don't know the full path, I think that's also part of the answer, and that's taken a long time for me to kind of come around to that. I've got to be sustainable and happy to be able to lead. And this analysis is so urgent and so pressing and so hard to kind of confront that it sometimes moves me away from doing those things I need to do to be we had good times, actually. We fought this stuff, but we loved each other and we made it work. And that's how you got to where you are.
So speaking of joy, first of all, I just want to say it's been joyous watching all of you on this panel. So I just want to, and I love that you brought up joy, Damon, because I think a lot of this work, to what Sanjay was saying about protesting, how do we take all of this work that we're doing into action, not being reactive, but really being thoughtful and proactive. And I think that joy is resistance. So I'm going to ask each one of you, what do you find as joy?
I think you guys have earned the right to call on someone else already.
Okay, but I started multiple rounds.
Monica. He was basically telling us to call on
Be hazing me. I find joy in a lot of things. I mean, you know, you and us. I find joy in the friendships at work. I find joy in the, you know, people who I talked to once on a Zoom who now I've seen here in person. I mean, like, that is so joyful. And I'll tell another story. I really am turning into an old black lady like that. It's happening right now, I think. So my kids are little, they're 6 and 4, and you know, MLK Day was always a very important holiday actually in my husband's family, so they would always buy a birthday cake and sing happy birthday to Dr. King on his birthday. And this year was a tough day, right, for when it fell, and so the kids weren't at school on that day, so we decided that we were gonna go to school, Chris and I, on Tuesday, and do the happy birthday celebration for my kids' school. My kids are like, you know, kind of the onlyest in the school too. And I made my little one, I made those preschoolers march and sing "We Shall Overcome." All these little kids just like walking around. And so when we came back home, my kids were very close to their grandfather, my father-in-law, started to sing the song just because they had been singing it at school, so they were singing "We Shall Overcome." And I think I thought that my father-in-law would sort of like think this is like precocious and cute, but he got really thoughtful and stopped and said, "It's really something to watch my grandchildren sing this song to me. You can't even imagine what that time was like." And anyway, so it's sort of like this like multi-generational, carrying things forward, learning from folks that have already, who found joy in all these moments. That brings me joy too. So anyway, I am a pretty joyful person generally, so I find joy in a lot of things.
Yeah, I'll say the multi-generational aspect, like we at Health Leads, we kind of, you know, in the most recent era went through like a lot of challenges inside the organization, sort of talking about race and figuring out how we were gonna respond to that in this particular space as well, which is really hard. And we went to Dr. Copeland, who works at Kaiser, Alex and I, and asked for some assistance, kind of helping us think managerially through some of the challenges we were having. He said, "Oh no, you don't have a race problem, you have an age problem." And I was like, oh wow. And it's this sort of transmission from like old to young of these like cultural habits. And so what I find a ton of joy in, as anyone who's met me in the hallway, like coaching my son in basketball. I missed the first panel because I was like coaching my son's basketball team. And this interaction where we're really listening to each other, we're really vibing, which I don't get to have with 11-year-olds otherwise. You know, mostly they're just ignoring me and I'm trying to ignore them. But on the basketball court, like we're really connecting, we're really vibing, and I think, you know, having coffee with folks, connecting kind of those stories from one generation to the next brings me a ton of joy. So thanks for that question. You guys have any responses you want to give?
I mean, similar to Monica, right? Like, we are not our jobs, we are not our politics, like, we are our communities and our loved ones and our relationships. And I think, you know, at the end of the day, whatever dimension that exists in, that is what brings me joy. The other thing that I'll say is, you know, everyone who knows me, I'm not an incrementalist. I'm a like, let's rip the Band-Aid off and fix this problem sort of person, which is ironic that I've spent my entire career in hulking bureaucracies that are not known for being nimble and agile. But one of my mentors early on, you know, taught me like, never waste a good crisis. And so I actually like, I run towards the crisis and the conflict. That everyone else is running the opposite way, and I'm like, no, this is where we should be headed. And you know, that's kind of the moment that we're in, and it's an opportunity to live our core values, to reimagine all the broken stuff that all of us deal with every day, and that brings me a lot of joy.
Wow, you guys are such good role models. I just read trash fiction. To each his own.
We all know each other way too well, so I'm gonna call you on that, because when I get really stressed, I watch bad Netflix reality television. When Sanjay got really stressed last year, he wrote a book on Medicaid
did.
policy in his free time. So that's kind
now
of
trash fiction.
ingenuous, yeah, to be like you read trash fiction while writing a book. It is a really good book. I highly recommend it.
And free.
You tell me, do we have time for any more? Any other? Do we have time for one more, Caroline? All right, looks like this is the last question.
I'm actually kind of sad that this is the last question because I'm the anti-Joy, and I'm really embarrassed that this was asked not before yours. But so I'm sorry because I've really needed some hope, and this week has given me a little modicum of hope. But what I'm going to push back a little bit on, Palav. You had mentioned that leadership matters, and I completely agree. And we've been fighting our leadership, and so we are losing sight of our joy. We're really struggling. And you said that everybody in the room can do something, and at some point we're going to be invited to not work, because we're pushing back so hard. So I might be reaching out for that recruiting opportunity. But
Always.
I'm wondering,
Door is always open.
I'm wondering then, at some point, what can we do? I think it was Dr. Taylor's talk. She was saying yesterday that our leaders aren't elected, or hospital administrators. What can we do? And so maybe there'll be some hope and opportunity and joy in this answer, but my question is sad.
I mean, I think we've all been there, right? Like at some point, again, to Damon's earlier analogy, like I am lucky that pretty early in my career, mostly because I'm so stubborn and I'm a Taurus, and I was like, these are my core values, and I'm not getting pushed off the path, and I'm just going. And I've had to leave organizations when I really cannot agree with the direction of leadership and where they're headed. So it's like, yeah, you fight back, you push back, you try to hold your leadership accountable to the core values and needs of the community. And sometimes if that doesn't work, you leave, right? There is literally no shortage of healthcare organizations that are desperate for talented, committed people to come and work and be a positive change. And don't be afraid to take that option.
And this is where we are a little bit, we're same and different. Same and different. It's been interesting to be in this seat because my primary relationship is with health plans, and that had not been kind of my primary relationship when I was in the delivery system side working in the county. And even folks that it feels like there's a big distance between maybe our value system. This is my lever of change is through those relationships, right? I cannot be effective or get my work done if we don't have some understanding of each other. And so I do just spend a lot of time trying to understand who is this person across from me or next to me, and think a lot about why am I having this physical reaction to you? Why don't I like you? And that's a me problem. What is it about you that I do like, that I can connect with? What are the similarities that we can pull from? And so to your comment about the marching and who's by our side, I'm not sure we have the luxury to keep running away. I think we gotta find we gotta work hard. We might have to. It's not running away. You should depart when you need to depart. But can we try to find the ways to lock arms first and humanize that person? So it's hard work, and this is the really hard part, right? It's the agape, it's the love. How do we find the love first? Try to. No, it's very difficult though.
Yeah, I'll just say I think we're going to need new institutions, right? We didn't have community health centers, and now we have them as a result of a lot of organizing. And we now have a public benefits corporation that has public accountability that's addressing social needs. So this is an opportunity to find these new forms of social and economic structure that allow us to confront the ills of racial capitalism, that were brought up earlier. We are going to have to form new institutions. We are going to have to say SIREN has to do research that tells us about new institution formation, this idea that we're going to continue these institutional structures that you're referencing with the same leaders in place and they're going to do something different is really wrong. Lauren talked about being a meeting stopper. I was in another National Academies conversation, and someone was talking about changing the decisions we make, and I was like, well, isn't it obvious we need to change the decision makers? It was like...
How'd that conversation go, David?
Yeah, meeting over, find a new panel to advise.
Never invited
on.
back.
Never invited again.
Not the right place for you, so I don't know if that's a synthesis of what they said, but I think that arm in arm with some people, and sorting through all that is going to be important. But acknowledging that's going to mean new social forms, absolutely, and it's going to mean new leaders making decisions, absolutely. And how can we kind of gracefully navigate that possibility? You guys.